Bismillah ar-Rahman ar-Rahim. Dear colleagues, let me introduce myself. I'm Hussain Raif, consultant endocrinologist at King Faisal Specialist Hospital and Research Center in Riyadh, Saudi Arabia. And it's my pleasure to be a part of this series of lectures across type 2 diabetes. These lectures deal with risks, cardiovascular outcome, and safety in the management of type 2 diabetes. And I will be happy to present to you today one of those presentations that deal with cardiovascular risks in type 2 diabetes. To me as a clinician, and I'm sure for a lot of you, the question that was asked for a number of decades, and since cardiovascular disease, morbidity and mortality is the major risk and killer for our patient with type 2 diabetes, the question was asked, can we decrease the burden and the risk of these cardiovascular diseases in our patient with type 2 diabetes? The answer was not straightforward, and in the last couple of decades we have been striving to have some sort of straightforward answer. However, I don't think we have a straightforward answer, but we have a lot of positive outcome that we can bring and be happy to apply to our patients. The first thing that can come in mind is, does control of blood sugar decrease the cardiovascular risk? And this is natural, since diabetes is hyperglycemia after all. And the second, whether lifestyle modification, weight reduction, etc., cause any decrease in the burden and the risk of cardiovascular disease. Unfortunately, although we think this is probably true, the evidence, as we will see for this, is somewhat borderline. However, we are very fortunate that we have better evidence that decreasing the burden of hypertension and dealing with dyslipidemia and probably antiplatelet therapy has direct impact on decreasing cardiovascular outcome in those patients. However, as we will see in other lectures, that there are some newer evidence that dealing with this major problem can be approached in some different way using some newer medications that will treat our patient with type 2 diabetes, but in the same time could decrease the burden of the disease, of the cardiovascular risk in those patients. Let's take those factors one by one. And as I mentioned, as diabetologists, the first thing we will think about is glycemic control. So what is the evidence that glycemic control would make any impact on decreasing cardiovascular complications in patients with type 2 diabetes? The strive to answer this question has, as I mentioned, has been there for decades, although it has accelerated in the last couple of decades. As you will see here, that even in the 1960s, the university group diabetes study has addressed this issue, and at that time, unfortunately, it kind of pointed that there was a possible increase in cardiovascular risk in patients who use sulfonylurea. There was a big shift of the use of sulfonylurea towards insulin in the United States based on the study, which was difficult to replicate after that time. The most promising study was the UK PDS. This is a very large study in type 2 diabetes that dealt with new onset diabetes, and for the first time showed us that we possibly could actually decrease the burden of microvascular complication and maybe macrovascular complications in those patients. Many more recent studies like the VADT, the ADVANCE, and the ACCORD studies has actually put more light on this issue, but unfortunately also raised some doubts. We will go through this together and make some conclusion. So let's go through these studies together, and as you will see that UKPDS dealt with large number of patients, anywhere between 1,800 in the VA study up to 11,000 advanced study. Duration is different, but they were substantial duration of like 10 years in the UKPDS study. The most important thing is to realize here the main inclusion criteria, which is different between these studies, which might have some explanation for the outcome of those studies, where UKPDS dealt with very fresh patients with type 2, newly diagnosed, whereas the Accord had actually patients who had long duration of diabetes and already established cardiovascular disease, or at least multiple risk factors. Also, we need to probably draw attention that the purpose of a study like Accord was extremely tight control of those patients, where HbA1c was aimed to be less than 6% versus the standard treatment, whereas the UKPDS, which was more a kind of day-to-day type of study at that time, aimed for more reasonable control, a fasting glucose less than 6, and the intensive arm, and just a loose control actually in the standard treatment, which was reasonable at that time, but not reasonable in the recent times. So the UKPDS, and for the first time, showed us without any doubt that controlling diabetes decreased microvascular complication, microalbuminuria, retinopathy, and other microvascular implication. It was all decreased by significant value. But when it comes to macrovascular complication, the result was a bit shaky or borderline. Although there was a borderline decrease in myocardial infarction with just a borderline p-value of 0.052, it didn't make it in all-cause mortality or diabetes-related death. So far, we did not have a very strong evidence for decreased vascular complication. What happened when we extended UKPDS for 10 more years, from 1997 to 2007, we started to see the impact of good control. Even in those patients who are now at average control, but they were intensively controlled before from the onset of their diabetes, now we started to see marginal but significant decrease in the cardiovascular, specifically myocardial infarction, by a decrease of almost 15%, comparing to those who did not have intensive control in the beginning. This was very promising. Now, when newer study like ADVANCE came to address this issue, and ADVANCE has a very large number of patients, again, the microvascular complications were clearly less in the intensive control group, but macrovascular complication didn't make it. There was no difference between the intensive and the standard group. As I mentioned, microvascular complications were clearly better, including end-stage renal disease, which was less in the intensive control group. Now, the Accord study is where doubts start to be raised about this issue. This is a study that included patients with type 2 diabetes for many years who have established or many risk factors or established cardiovascular disease. And the aim was kind of unrealistic to decrease their HbA1c to less than 6%. Actually, the study achieved about 6.3% in their control as an HbA1c value, versus the 7.5 in the standard group, in the standard therapy group, which is also much better than we saw as example in the UKPDS standard group. But to our surprise, instead of decreasing cardiovascular mortality and all-cause mortality, actually there was an increase in cardiovascular mortality. And this came mostly from cardiovascular causes, although non-fatal MI was still better in the intensive group. This was a little bit of shock to the community of diabetes and diabetologists. Now, the VA study was somewhere in between in terms of targeting control and the risks of those patients. And at the 6 years, there was no difference in intensive versus standard therapy in terms of decreasing cardiovascular event or primary outcome, which was a combination of cardiovascular events. However, when this study was extended for 5 or 6 more years, there was some advantage for the intensive group in decreasing the primary outcome of cardiovascular risks. Now, if we put all these studies together to try to understand where UKPDS and the VA to some degree showed us some positive results, ACCORD showing negative results, and the ADVANCE being neutral. If we put all this in meta-analysis like this one, actually we could not prove that intensive glycemic control would reduce mortality or cardiovascular mortality. But if we looked more carefully, there was a little bit of advantage in terms of decreasing myocardial infarction in the overall outcome of those studies, and also in decreasing major cardiovascular events. So it seems to be that diabetes control, if anything, will not change mortality as much, although it might decrease a little bit cardiovascular events. There's a lot of explanation that is a little beyond this lecture to why is this case. However, it shows to me the difficulties in decreasing cardiovascular burden by just targeting glucose control, although it may be possible if we do it very early and choose those patients who are not at very high cardiovascular burden from beginning. This is just a summary. Of course, the slide shows a summary of all these conclusion or result of those studies. All of those studies showed decrease in microvascular complication, and there was increase in mortality in the ACCORD and the intensive group. There was no impact on mortality in the rest of the group, and there was a borderline or no effect on other cardiovascular diseases in general. Of course, the question is why, and again, there's a lot of discussion that happened and as a sequence of these studies. But one of the things that looked at is hypoglycemia, and whether hypoglycemia could be a factor in actually causing this increase in cardiovascular events and mortality in a study like an ACCORD study. I don't think the answer is clear, and there is a kind of conflicting data whether hypoglycemia is a major risk, although it has been thought as a culprit. So what else we could do? Lifestyle. We always advise a good lifestyle weight reduction. Do we have any evidence that such an intervention will decrease cardiovascular risks or mortality? In the Look Ahead study, which is a study that looked in the effect of weight loss and lifestyle intervention for a short term, there was a clear effect on risk factors. So those who had intensive lifestyle intervention, here in the red bars, had less HbA1c, better blood pressure, less LDL cholesterol, and altogether they were more who achieved those goals in the intensively treated lifestyle intervention. This is probably not surprising and certainly a good news. But does this affect cardiovascular risk? And in this study, there was no effect on cardiovascular risk. Of course, this is 10 years data from the study, showing that it did not improve cardiovascular risk in spite of the weight reduction that occurred over these years. So again, we have another intervention that has not been proven yet to be extremely effective in decreasing cardiovascular mortality, although it does improve the risk factors and certainly improves diabetes control. What about the other interventions that we have? And of course, antihypertensive therapy, since a lot of our patients with type 2 diabetes are hypertensive as well. Here, I think the evidence is better and certainly is encouraging. And in this meta-analysis, they looked in many studies to see whether decreasing systolic blood pressure by 10 millimeter mercury would affect, how much would it affect cardiovascular risks. And most of these studies that were done, they're a little bit older studies, has shown actually major impact on cardiovascular events and mortality. As we see here in this meta-analysis, a decrease by 10 millimeter in systolic blood pressure decreases all-cause mortality, decreases microvascular disease, especially stroke, which seems to be the most sensitive to decreasing systolic hypertension, heart failure, and also microvascular disease. Almost the microvascular disease decrease would be similar to what we see in improving blood glucose control. So this is extremely encouraging. The UKPDS and other studies like ADVANCE has clearly supported this outcome and this conclusion. However, when we try to do it a little further in the ACCORD, where we wanted to decrease systolic blood pressure to less than 120, thinking lower is better, this did not work as well. So I think we reached a limit in terms of how much more we can get from decreasing systolic blood pressure. We already got reasonable decrease in the cardiovascular risks. But when ACCORD, this is a study that done on patients with diabetes, aiming to decrease systolic blood pressure to less than 120. The outcome was a little bit more than 120 versus the baseline, which was about 135. There was actually no effect on decreasing cardiovascular mortality or risk any further, except for stroke. That has decreased slightly by decreasing the systolic blood pressure. So in general, of course, decreasing systolic blood pressure and treating hypertension does a lot in decreasing cardiovascular. And as in this analysis show, that even small reduction in blood pressure can reduce the risk of cardiovascular disease in those with high risk. So high risk patient, even a little decrease in blood pressure, systolic blood pressure, can have an impact. So there are different analyses, of course, whether if we decrease systolic blood pressure from a baseline more than 140 or less than 140 would make any difference. And as you see here, that it seems like, as in the blue dot, which is systolic blood pressure baseline, more than 140, you made a difference. When the baseline was less than 140, the difference was less, except in the stroke, which means that once we reach a systolic blood pressure of 140, we're pretty much reaching the limit of how much extra benefit we can get from decreasing blood pressure. And this is basically what the ACCORD study has shown. And where was it different from the previous study where the baseline systolic blood pressure was much higher, example in the UKPDS, which was almost 170. So based on this, a lot of societies has changed their target for systolic blood pressure control. and to say it's less than 140/90, instead of the previously thought that maybe 120/80 or 120/70 would be a target. So at this point, 140, less than 140/90 or over 85 would be a very reasonable target for our patients with type 2 diabetes. And it's, of course, elderly, where we need to be careful, where we can accept a little bit higher limit of blood pressure. Another very positive impact we could impact on our patients with type 2 diabetes and decrease their cardiovascular burden would be controlling their LDL cholesterol. Fortunately, we have a lot of evidence for this, and this is true whether patients with type 2 diabetes have already established cardiovascular disease, as in the secondary prevention studies, like the 4S or the CARE, or those with primary prevention who had no established cardiovascular disease, but they have diabetes. And in those patients, of course, a lot of those studies were done on diabetic and non-diabetic, and diabetic seems to get benefit from primary prevention and secondary prevention as much as those patients with no diabetes, almost the same. Many studies have shown that the lower the LDL, the better is the result, and this is true for non-diabetic as well as diabetic, although the advantages could be slightly different between the two groups. But even newer studies like Improve It and the studies now dealing with PCSK9, which is the most advanced or newer agents in lowering statin, has again proved this concept where lower LDL seems to lower cardiovascular events even further. So we have two successful stories here, which is the antihypertensive therapy and the lowering LDL. But we have to understand that with lowering blood pressure, there is a limit, and with lowering LDL, although lower is better, there might be also a limit, because there still would be a significant residual risk of cardiovascular disease, even if we lower cholesterol to the lowest point we think of. Antiplatelet therapy, although we're not going to go in any much details here, is again a therapy that has been recommended for our patient with type 2 diabetes. Of course, not everybody, but there are the ADA and other society recommendation. It can be recommended as primary prevention in patients who have other risk factors like hypertension, or as a secondary prevention in those who have already some sort of cardiovascular or cerebrovascular disease. Of course, this should be always outweighed with the risk of antiplatelet therapy like GI bleed, and there is clear indication where you should use it or not use it, or the kind of the borderline cases where you have to weigh the benefit and the risks. Now, there is something called multifactorial approach, and I think this comes from the Steno model, or what we call the Steno model of approaching type 2 diabetes. As you know, Steno is a diabetes center that has predicted that dealing with multiple factors and risk factors of type 2 diabetes could lead to a good result and decrease the outcome, decrease the burden, and improve the outcome of cardiovascular risks in patients with type 2 diabetes, even way before the newer study has come. And this is very encouraging because this common sense approach proved to be effective. So that approach would deal with everything together. Dealing with the blood pressure, dealing with the LDL cholesterol, dealing with the antiplatelet therapy, improving glucose control as much as possible, and improving lifestyle as much as possible. All together seems to have an impact, and the Steno 2 study has shown actually that you could decrease cardiovascular risks and mortality in those patients. And again, this slide tells us that cardiovascular risk reduction in type 2 diabetes might require actually more than one intervention, where you gain little from each intervention to add together the results in improving control. So as example, if you decrease systolic blood pressure by 4 millimeter mercury, you could decrease cardiovascular events by 12%. If you lower LDL cholesterol by 1 millimole, you could decrease cardiovascular events by 8%. And for HbA1c, 0.9 or almost 1% will decrease by 3%. And this is calculated for 200 patients for 5 years. So again, the Steno model here, in the Stenos 2 study, intensive approach for patient and approaching all these risk factors, those group had more than 50% decrease in the events over the period of almost 100-month follow-up. So again, I think the best conclusion we can have from going through all these studies is starting early in our patient with type 2 diabetes, especially in terms of diabetes control, but also approaching all these risk factors together. And as the Steno 2 model, we think that a reasonable approach, as also recommended by many societies in Europe and North America and other places, dealing with the blood pressure and decreasing the blood pressure to a target of less than 140 over 90 or less, and using ACE inhibitors or ARB like the Steno 2 model in treating those patients, lowering the cholesterol to 2.6 millimole or better, and even now 1.7 millimole is recommended for the very high-risk diabetic or those who have established cardiovascular disease, using statin and other therapies. Now, of course, ezetimibe also may be indicated in certain patients. Cessation and refrain from smoking and smoking cessation in those who smoke. Dealing with hyperglycemia as much as possible, but within the lessons that we learned from ACCORD, where we target the control for those who are fresh and has low burden of cardiovascular risk. Here where we try to control and have the HbA1c with less than 7% if possible, but accepting higher level of HbA1c for those who have already cardiovascular risk or have long duration of diabetes or elderly to decrease the possibility of hypoglycemia and to avoid results like the ACCORD one. And using antiplatelet therapy for those who have higher cardiovascular risks, then all these approaches together might add up to significant reduction of cardiovascular burden. Would we have any extra risks after doing all of this? Yes, and we have to deal with it. Maybe using newer approaches, newer model of therapy, and definitely thinking out of the box. So let me summarize here. Beneficial effect of glycemic control on macrovascular risk has not been established in a prospective long-term cardiovascular outcome trial. However, beneficial effects of LDL cholesterol lowering, blood pressure lowering, and antiplatelet therapy on cardiovascular risks are well established. The multifactorial approach is recommended for controlling cardiovascular and microvascular complications in patients with type 2 diabetes. Pursue recommended treatment goals with regard to glucose, blood pressure, and lipids. Pursue lifestyle intervention. Provide antiplatelet therapy if indicated. Although we know that some will fail, and we can decrease the burden to a certain degree, we think future therapies and renovation in this field will be coming and should be coming to decrease the risk even further. Thank you very much.